Hello, this is Dr. Joosse at Joosse Family Orthodontics in Williamsburg, Virginia. This is a great case, a complicated case, and one that took a long time, but there's so many valuable lessons in here that I couldn't help but make an educational video about it. And so we'll try to walk you through what happened and what some of the main points are as we go through. All right, so meet Lydia. I'm showing you this picture because you're going to see how much Lydia grew up over the entire span of treatment. And to lay this out for you, in orthodontics, sometimes we think about early treatment, which is when we treat kids when they're really young. And then we call that a phase 1. And then a phase 2 where we treat them later and we're really trying to make sure that the smile's perfect and the bite's perfect. So I first saw Lydia when she was 7 or 8 years old. I can't remember if she was 7 or 8 in this picture. And that's the main point number 1, is it's great to be able to see kids when they're 7 or 8, because what we saw when she was 7 or 8 really allowed us to do all the things that you'll see later on in this video. So let me show you what's going on in Lydia's mouth when she first came in. Lydia has something that we call a Class 2 Division 2 bite. Class 2 Division 2 is not something you need to remember. That's not so important. What's important is that this happens commonly. Lots of kids have this, and it tends to be genetic, and it almost always looks the same. So what does a Class 2 Division 2 bite look like? Well, upper front teeth are usually kind of tipped backwards, like the 2 front teeth are tipped backwards. The next 2 teeth, here and here, are usually kicked forwards. The upper front teeth typically overlap the lower front teeth really excessively. So you can see 2 out of the 4 of her lower front teeth, but you can only see a little bit of them here because of how much these upper front teeth and these lower front teeth are overlapping excessively. And then when you look at the side view here, again, you can see how these 2 front teeth are tipped a little bit backwards. The next 2 teeth are kicked forwards. You can see the extent to which the upper front teeth are overlapping the lower front teeth. And then the other part of this that I like to mention to people is if we just waved a magic wand and made these front 4 teeth straight, then you would actually appreciate that Lydia has a bit of an overbite. A distance from her upper front teeth to the lower front teeth would be excessive. And that's actually because of how the teeth relate in the back of the mouth. That's not super important for the purposes of this video, but very, very common appearance. And I should say that at this point, I've showed you nothing that really drives me to want to treat Lydia at this point. A lot of times Class 2 Division 2 cases are something that we can wait. We can wait for the baby teeth to get lost, and we can treat that later in the future. Sometimes people are concerned about the appearance of these front 4 teeth, and they may elect for kind of elective treatment, which is really more of an aesthetically focused early treatment. But as far as everything you've seen so far, I don't really feel the need to do anything about. These are her upper teeth. Again, you can see that those 2 teeth are kicked forwards. And then these are the lower teeth. Whoa, all of a sudden we've got a little bit of a problem. This is quite crowded. And I recognize that this is quite crowded. And so my treatment for Lydia as her early treatment was a lower lingual arch. And what a lingual arch does is it holds from this molar, which is a permanent tooth in the back, all the way over to this molar. There's a wire that runs behind all the lower front teeth, and it holds the space from molar to molar. Why does it do that? Why is it important? Because these 2 baby teeth, that's her right side, and these 2 baby teeth on her left side are larger than the permanent teeth that are going to supplant them. And so if we can hold all the space, then we've got a chance to get everything in the future, despite how crowded it is right now. So that lower lingual arch is really, really important. And that's point number 2. Lower lingual arches don't move teeth. They hold space, but they give us a lot of flexibility for the future. And you're going to see what that lingual arch does for us in the future. I'm showing you this x-ray only because, at this point, when I saw Lydia, everything on the x-ray looked normal. The only thing that I'm not happy about is the lower crowding. We don't need to unravel that lower crowding, as I said before. The main point is we just need to kind of wait and see. I want you specifically to look at these upper 2 canine teeth. They look pretty symmetric in terms of where they are vertically in terms of coming into the mouth. They look pretty symmetric in terms of their angulation into the mouth as well. So again, this is all when Lydia was 7 or 8 years old. And then just a reminder that this is the only thing that we're really treating. We're not trying to resolve this crowding at this point. You can resolve the crowding at this point, but in my opinion, it's usually overkill to do that. It's unnecessary. All you need to do is make sure that this doesn't get worse. So we placed that lower lingual arch. You can kind of see in this x-ray here, this x-ray was taken actually 3 years later than the one that you saw before. And so we've been watching Lydia over this time. This lingual arch has been in place. It's been making sure that we're not losing any space. But look at what happened with our upper canine teeth. The one on her right side, the left side of your screen, is still pointed directly down into the mouth. It's descended down just like it should be. But the one on her left side kind of got stuck. It has not changed in angulation. It is not pointed directly down into the mouth, and it's had a poor angulation. The risk of these canine teeth is that left alone, this tooth might continue to move the way that it's moving. It could do damage to the roots of the adjacent teeth, sometimes in irreparable ways. I've actually seen a few cases where these canine teeth have damaged these roots in such a way that they can no longer be saved. They're no longer viable teeth, and so that's a big problem. This is now a reason that we need to get involved. We need to do something to bring this canine tooth in, and there are three ways that we have to try to influence canines to come in. Number one, you can expand and make the upper jaw bigger. We are going to do that. Number two, you can take out the baby teeth. I like to say that teeth that are stuck like to go to the light. So if we remove the baby tooth here, this adult tooth should come down into the space. And the third thing we can do is we can consolidate space to make sure that all of our space ends up right here. If we give this canine tooth more space to come in, it's more likely to come in. So we'll get to exactly how we treated that in just a moment. The problem with the option number one about using a palate expander is that, yeah, we can expand the upper jaw, but I'm showing you this picture because at this point, Lydia's bite in the back of her mouth is actually pretty good relationship. I like how the upper teeth are relating to the lower molars. And so if we expand the upper jaw, we would be pushing the upper teeth out too far, and it would no longer correspond well to her lower teeth. Now, the lower teeth are tipped inwards, like towards her tongue. And so if we bring these lower teeth out a little bit, that gives us the ability to expand on the upper jaw and be really effective with our expansion. And so that's just what we did. So if I can make a second main point here, regular checkups along the way were valuable because we were able to see that canine tooth that hasn't been coming in. And so we were alerted to a problem and we're able to address it early and with minimal intervention. So here is where we are currently on the lower. Remember, this is about 3 years after those last set of records that I showed you. It is no more crowded. It is no less crowded. It may look a little bit more crowded because you're seeing another adult tooth trying to poke in here, but we haven't lost any space, and so that lingual arch has done a great job of preventing space loss for us. All right, so this photo is now about a year later from the last set of pictures. So we're now 4 years after the starting pictures, and we've placed a palate expander on the top. This has made the upper jaw bigger. We've extracted the baby tooth where the adult canine that's stuck needs to come in, and we've used Invisalign on the lower teeth to try to unravel some of the lower crowding and to upright these lower molars. So the Invisalign has been a great tool for us to upright the molars, which lets us maximally expand the upper arch. Here's a picture of where we are currently with the lower teeth. This again is after the lower Invisalign, and you can see that these lower front teeth are definitively not as crowded as they once were. And you can actually now, in your mind's eye, if you bring this canine tooth out into the space, you can kind of imagine that there is now space for everything to fit in. And we still have these two baby teeth in the back that are bigger than the adult teeth. So not only does it look pretty good right now, but we actually have a little bit of extra space, which is great. Reminder, this is where we started. This is 1 year earlier to the picture that you saw just before it. So we have unraveled some of that lower crowding. Here's a picture of our palate expander. You can appreciate that this metal piece and this metal piece used to be touching, so that's the extent to which we made the upper jaw bigger. This little loop on the end was something that I put into my design just in case that canine tooth did not come down on its own. I was ready to rescue it, and this was going to be where I was going to pull from. But the good news is that with the expansion and with the extraction of the baby tooth, all of a sudden our canine tooth starts normalizing in its eruption. So it's pointed straight down towards the mouth, and I'm realizing that, hey, if I just start making more space for that canine tooth, we're going to be all right. So second main point, before we ever go into a surgical try to rescue of a tooth, one of the great things to try to do is can we expand the upper jaw, because that's going to help canines erupt? Can we extract the baby tooth? And so we've employed already 2 of our 3 methods, and now we're about to employ our 3rd method, which is consolidate space for that canine to get it to come in. All right, we put braces on, and again, the braces went on about 4 years after we started. When we first saw Lydia, about 3 years after, 1 year after we did the expander and the extraction of the 1 baby tooth. This is a picture just showing that we have that canine tooth in. I'm going to show you a couple quick pictures just showing, hey, we had braces on the teeth, and we've been able now to get everything nice and straight. This is kind of midway point in the braces, so we're 1 year into our braces. Here's our upper teeth, and then we get to our finish. And so our braces portion of this treatment took 2 years, but we got a great result here. One of the things that I'd like to specifically point out is that there's less overlap between the upper and the lower front teeth. This is good for the health of the bite. Here are our lower front teeth, everything nice and in place. Here's our upper front teeth, really great alignment of those upper incisors. Here's Lydia smiling big. And here's the comparison. So, you're looking at pictures that span quite a ways here. You're spanning about 6 years from start to finish. And remember, the first 3 years of that, we only had that lower lingual arch, that lower retainer in place. After the first 3 years, we used lower Invisalign and the upper expander, and those were in for about 1 year. And then after that, we had braces on the upper and the lower teeth for about 2 years. So that's how we kind of spanned our 6 years. But here's a comparison of the crowding when we started to our finish. We switched from using photographs to using scanned models. Much better patient experience that way. These are our upper teeth. Again, you can see the nice alignment of those upper front teeth. And then a picture of our teeth from the front. Again, you can appreciate how much less overlap of those upper and lower front teeth there are. And the best part is getting to know Lydia throughout the process. And she was a fantastic patient, did everything that we asked. And I couldn't be more happy for this girl. I'm super proud of the result. And, thank you, Lydia, for being an amazing patient. So just to kind of recap the main points. Number 1, is seeing kids early at age 7 or 8 is always a great thing because we're able to intercept problems early. In this case, we used a lower lingual arch. Lower lingual arches are fantastic. Even though they don't move teeth, they prevent us from losing space. That was the key to success for Lydia's treatment. Even though things were really, really crowded in her lower arch, we were able to hold all the space so that we could get everything in place later on. Number 3, regular checkups are a good thing. We were able to see that those upper canines, that one upper canine in the upper left went off track. And so we were able to intercept that early with our expander and with the extraction of the corresponding baby tooth. And number 4, we used a lot of different tools in this case, right? We used a lingual arch at the start. We used a palate expander. We used Invisalign on the lower arch while we were using that palate expander so that we could maximally expand our upper arch to match the lower teeth. And then we used braces on the top and the bottom teeth. And so lots of different orthodontic tools. A lot of people, just ask about, well, one thing or the other. And sometimes there are cases where we like to mix and match these different tools, and it really just depends on what's going on in that specific case. But we always need great partners in treatment, and I want to give Lydia credit here too. Great partner in treatment. You're partially responsible, Lydia, for this amazing result. So thank you for being an excellent patient, and thank you for listening if you made it this far. I know that's lengthy, but it's a complicated treatment, and hopefully it gives you a good idea too of how early intervention can set us up for success later on.